We'll now invite Professor Mangat DOGRA to talk about lasers in ROP. Okay. Yeah. Interaction, yeah. We have a panel discussion at the end. We'll have time for that.
A lot of time. Please keep your questions ready. Blast. We will really be happy to hear your, perspective and, interact so that we all learn from each other.
Good morning, friends. I'm going to talk on a subject which I've been talking for a long time because been involved in this work very, very long. These are my financial disclosures. We all know, I think laser was a gold standard. We don't call it gold standard now because it is a standard of care, but it has got now different connotation. The way it has been, we are doing it and still we need to do it. It was a diode laser delivered through a laser indirect ophthalmoscope in a congruent manner. And one was almost like congruent, and that's how we used to see plus disease as seen here regressed first, and 90% or maybe it varied, it could go even to 95% attained favorable outcome. So great treatment, no doubt. And subsequently, I think it was our group only. I think we advocated very strongly 532 laser, which happened accidentally because the diode conked off. And now perhaps most people are using 532 laser, which is the same laser used for all the retinal problems. So I think we are much better off, and we have shown conclusively that it does as well as the diode does. And this is one such case treated here. You can see it. And I think even Anand also showed posterior barrage laser. This may even be required at this time because you might have some cases where it is already proliferating, patient has come late, infant has been brought late, or you have a 4A sometimes, and if you do it, I think you may get a rewarding result like this. And so I think you can see it still has a role and should be kept in mind. And laser is also possible through the wall of incubator, and this was very especially important, I think, during the COVID time when perhaps this was the way many were treated. Even the contraptions were made based on this particular publication. And we know, I think once we talk of the previous classification, aggressive posterior ROP, and way back in 2009 when we published, it had an unfavorable outcome in large number of babies as once we had aggressive posterior ROP, which is so common in our country. And you can see it is almost like 71% only having a favorable outcome. And we also looked at, because of this, the risk factors, what leads to detachment, which is a serious issue, especially the posterior zone 1 ROP was most important, or you have a pre-existing or a new onset fibrovascular proliferation. So that also leads to retinal detachment. So you have to keep all these things in mind. Even if you have a pre-retinal or a vitreous hemorrhage, that will also lead to contraction, or obviously need for repeat laser would be in a severe case where disease is not going down. So this was way back, we did this study and published. And also this is the first posterior zone 1 study, and otherwise it used to be just in passing in some studies, which is published. And we saw that almost 79% had unfavorable outcome with laser only. So that was the time. It was very important for us to bring it, and we did suggest here perhaps they need combined treatment. That means they need anti-VEGF, laser, and even some cases surgery subsequently. This is, I'm showing example from that time. Posterior zone 1, the vessels are hardly reaching even the fovea. We did good laser as much as possible we wanted to. And you can see not only perhaps it contracted, it produced a stretch break. Once you have a stretch break like this, howsoever the big surgeon, maybe it will be a problem to fix this retina for anyone, especially in a ROP. I think anti-VEGF Anand has already covered, but most would use as for AROP and Zone 1 he already mentioned. And of course, there are several trials which have been done, and we have a problem with especially I would say the late recurrences in long-term follow-up, and he also talked about that. And so the combination treatment, once we talk of combination, laser is required. I don't know, I put a query here, once the vessels have reached zone 3, whether it is required or not. According to me, perhaps it is required for all cases, because I feel they're going to lead later on to problems, lattice, holes, detachments. I think when we did laser, it was a finite treatment. Nothing was required, and nothing would detach later on. It will never, but we're going to see a lot of issues because of this bar business. So at this time, ideal is deferred laser. Let the vessel grow till the time they are growing or recurrence occurs, and do the laser that time. That's what we feel. And also the comfort level and the problem of not having a general anesthesia with everyone was also mentioned. I think that one should keep in mind. And of course, we know that anti-VEGFs in these severe situations, which has been mentioned here, they are followed by less extensive laser. We want to preserve more retina. So definitely, I think in these cases, we have shown that, of course, bigger baby would need, and this is the way we, in the beginning, we treated right inside zone 1. We came all the way, and these scars, they looks at everything. We had a small tube left, and then we started sparing with just zone 1. We spared, and that we did. But now you let the vessel grow into posterior zone 2, and that's what you can do. That is shown in the last picture here. And of course, I would like to mention about this. I think Anand already mentioned about Firefly, where they compared results of Eylea, which were comparable with the laser as well as the Eylea injection given. And so here, they also talked about high myopia, not the myopia, maybe relatively little more in laser group as compared to not. I'll show you one case here of a Eylea injection given posterior zone 1, and you can see a lot of problems in the baby. And this is 2 weeks later. You can see plus disease has gone down, and 5 weeks later you can see vessels have grown. They have now gone on beyond zone 1, and 9 weeks later after Eylea you can see what is happening, that the vessels are further growing. But 16 weeks there's a problem. We do have again the issue with, and I'll show you here in the angiogram. Now happy situation. These vessels have grown, they have gone beyond. So of course this child required laser treatment, which was done with 532 laser subsequently. So I think that is what we want to achieve. We won't let these vessels go beyond, and then perhaps we can treat them. So issues with the current laser are, earlier laser treatment was gold standard, and a finite treatment I already mentioned. And in which cases only lasers should be done is also a question mark these days, because it's so variable depending on who is doing it. When and in which cases do the laser after anti-VEGF should be done? That is another one. That is, this is after injection. Should we laser all eyes with PAR? Which according to me, I feel that they should be, because we laser all eyes with fever. We laser all eyes wherever we see fever. And I think this is one survey which I just recently, they have an international survey, preferred treatment pattern of ROP. So they have people from various countries. So anti-VEGF preferred for AROF in 64% and type 1 in 71%. And type 1 in posterior zone 2 also, although the number was like 50-50, 56%. So very interesting. The majority use laser as a first line treatment of ROP in interior zone 2. That means posterior they were injecting. Majority I'm talking about, but it was 50-50. And type 1 in zone 3. And laser preferred for repeat treatment following anti-VEGF. I think this we feel very strongly that second injection is a problem. We may have more issues with that. I think it's much better that we laser such eyes. The preferred anti-VEGF, even in this survey, was a bevacizumab. So I think very interesting results in this survey. So in conclusion, laser treatment is still considered standard of care for treatable ROP, as well as, of course, it is required after anti-VEGF, and most would use as I said, anti-VEGF for AROP and zone 1. And anti-VEGF injection will be followed by a need for less extensive laser. This we have seen, everybody has seen. But the indication for laser needs a lot of modification. I think that is what we have to come out from the IROP and other organizations, that what are going to be the new indications. Where are, these will be both without anti-VEGF as well as with anti-VEGF. I think that is very, very important. So thank you very much, friends, for patient here.
Thank you, sir, for summarizing it so well. In this era of combined therapy, laser is still here to